Welcome to BKC's Health Beat, the show that takes the pulse of our country's healthcare system. I'm Malan. We are well into our 7th administration.
I will be faithful to the Republic of South Africa and will obey, respect and uphold the Constitution and all other law of the Republic.
And the job of Health Minister belongs to a career civil servant whose task it is to roll out the National Health Insurance intended to transform South African healthcare. Can Motsoaledi keep some staggering promises from the ANC about fixing our country's divided and unequal health system? Dr. Motsoaledi, thanks very much for making the time to join us today.
Thank you, Mia.
You've been Health Minister for 3 months. What have you done?
I came into the department when already a debate was raging, so it was in a way a baptism of fire about the national health insurance and the court cases already. I have to sit and study them, see that, what type of lawyers were getting, brief them, get all the information and put it together.
This time around, your second time around as Health Minister, it's a little bit different from the first time because you're operating within a government of national unity. Do you think the NHI is going to be your biggest challenge within the GNU?
Not only within the GNU, the issue of universal health coverage, or which we call NHI in South Africa, and globally is called universal health coverage, is a challenge to any country.
Many people, and you've heard that criticism many times, say you should first fix the public health system before you implement the NHI.
Any human being who stand up and say, please fix the healthcare system before NHI, he's either is a joke or is extremely ignorant or is so greedy that he wants to put something as an obstacle that he knows won't easily be removed.
Let's watch a story that shows the typical struggle that many have in the current healthcare system.
Originally from a farming village called Langkloof in Mpumalanga, Emma Mtimunye is staying with her sister who lives in KwaMhlanga, about 75 kilometers from Pretoria. Emma is here because she needs to be closer to Kalafong, a tertiary public hospital with specialized care. She was diagnosed with cancer 20 years ago.
2005, years before, ek was nie reg hier op en ek kan by die maag nie.
At the time, Emma's local clinic referred her to Kalafong Hospital. There she was diagnosed with cervical cancer, the most common cancer among black women in South Africa.
Ek het daar geslaap 4 maande, geslaap van die cancer.
For her firstborn son Themba, it was a massive blow.
Kona ukugula kukamama kwangizwisa ubuhlungu kakhulu ngoba le time agula bengingimi ngedwa nje obhekelele sonke lesimo, ngiyaphansi phezulu kungekho umuntu osebenzako. Sometimes kumele ngiyombona esibhedlela, anginamali, kumele ngenze inkoloto and angeke ngiye esibhedlela ngingakamphathelanga lutho. I have to buy something for her. Izinto ezinjengalezo kwangilimaza kakhulu nje nasengqondweni.
From Kalafong, Emma was referred to the Steve Biko Hospital for radiation. It helped her cancer, but damaged one of her kidneys, a common side effect of cervical radiation therapy.
Daai radiotherapie het my gebrand, die pepies van die pipi. Toe my pipies het sommer net so geloop het.
Now one of her kidneys no longer works. The family says it took 6 months before she could get a booking for a scan.
The last month, udoktor waba khona la sibiza khona bamusa khona escanning. Babuya kulaba sitshela khona ukuthi angeke bakhona ukumenza operation. Ngoba operation abangamenza kuyoba i-risk ukuthi ngenzeka lose impilo yakhe.
As ek uitali die kidney gaan doodgaan.
Emma has to have a bag to drain the urine from her bladder. Free at the hospital, but involving more travel that the family cannot afford.
Om te gaan, die een keer ek 85 rand. Them is 85 rand. Zindle is 85 rand.
Sometimes she goes all the way there, and there are no bags.
Pateke krayom ni eleselit ni sakine.
In early August, when Emma was too weak to collect bags, her niece Gugu forked out more transport money to fetch them from Kalafong for her. This time they had bags. The nurse suggested that Emma use a discharge letter she should have received after her scan to try to get bags closer to home.
Let's hope vele ukuthi ngale kwamhlanga bazosenzisa yona izinto ukuthi zibe sharp.
The Gauteng Health Department reiterated that they didn't have to collect the bags exclusively from Kalafong. Nonetheless, Emma's story is an example of a cumbersome and fragmented system that makes patients carry the cost of its financial problems.
We've seen an insert now of Emma Mtemunye, who got kidney damage after radiation for cervical cancer at Steve Biko. And that is, of course, quite a common symptom of radiation. But what she's struggling with at the moment is that she needs these urine bags, and she gets sent from pillar to post and has to travel so far to get them. Why can't she just get them from a primary healthcare clinic?
It was quite unfortunate that she has to struggle with a simple thing like getting a urine bag. But in the manner in which the healthcare system is run, in a fragmented manner, the hospital that treated her and gave her the bags did not do a follow-up to make sure that she can get them near home. And part of the missing link there are community health workers, because the community health worker system links health facilities with the patient at home.
So we've got tens of thousands of community health workers in South Africa. Why did Emma not have one at her house?
Our problem was that we already had thousands of community health workers who were not chosen through any criteria, but who were sort of volunteers. And this happened during the height of HIV and AIDS, especially during that time when ARVs were not being provided. Many community members stood up and volunteered just to feed you, just to wash you, just to clean you, to make you comfortable. That was very noble work. But community health work, it must go beyond understanding certain symptoms and signs, understanding certain basics of medicine. And that's where we are at the moment. We have started training people, but the majority of those who are there have not gone through that type of training.
I recall that ward-based system of community health workers were introduced many years ago, and the health department worked on training courses for community health workers so that they have standardized training. Why are we here?
Money, Mia. You need a huge budget to do that. When you think about the health workforce, you want a nurse. That's what the community is expecting, by the way. You need a doctor. Obviously, the community health workers need to be guided by them. So you don't rush in and leave a hospital with no nurses and doctors, and rather go and hire community health workers.
So where are we going to get the budget?
Well, we'll have to try and work very hard to try to get the money. That's why, Mia, we are so determined that we need to have universal health coverage, because then you pool money together for the whole country. Unlike now that huge amounts of money are pulled in for very few people, actually for only 14% of the population. And the woman we are showing there falls in the 86% of the population, where resources are very scarce.
We're going to talk more about financing and the NHI later in the program, but there was another problem at Kalafong. Clearly they have a problem with keeping supplies in stock, because sometimes Emma travels there, she gets back, sometimes she doesn't. So how are we going to fix that? That's not money, right? That is having a better system.
I've heard many people in the media talking about it's a simple problem of management. Managers don't fall from the sky. They are trained over many years.
So what kind of person would need to manage the stock for things like a urine bag, and what can be done to fix that? How can we help Emma?
We are putting together a system which controls stock, which is sort of an IT system, whereby people must see. And sometimes because you are dealing with human beings, they just become careless. Some years back, we've already given this type of gadgets to nurses, even at the clinic, where you just press and see what you are short of and make orders immediately.
Would it be fair to say that what Emma has experienced is a very common situation across our public health system?
I'll say it does happen quite a lot, but it's going to be very difficult to say how common is it. Because you see, Mayor, when we check you people in the press, everybody will believe the South African system has actually collapsed. Actually, it was announced at some stage when I was in health that the whole healthcare system has collapsed. But when you look at the number of people that have been treated, and many of them successfully, that is not looked into. But that does not detract from the fact that there are people who go through hardships like Emma. We have got to work as a unit, not competing against each other, because if we do, things will not happen in this country.
After the break, we asked Dr. Motsoaledi about the NHI and the anxiety it's causing. You're with Healthbeat, and I'm talking to Health Minister Aaron Motsoaledi, who is well into his second bite at the job. Dr. Motsoaledi, what's harder, being Health Minister or Home Affairs Minister?
I'm still making up my mind about that, but obviously the healthcare system is very huge and much more complex than Home Affairs. Somebody made a statement the other day. He said all over the world, there's no game. Health ministers, they don't usually win. Whatever you fix, something else is going to be pointed at and say, but this one. When you say you fix that one, they are going to say that one.
Now, one of your main tasks is going to be to implement the NHI.
Absolutely.
And you've kicked off with a roadshow. I believe it started off in KwaZulu-Natal with a meeting with doctors. But there's also already been criticism against this roadshow. Business has criticized and the DA has criticized, saying the roadshow is not consultation, that's just a roadshow. So what's your aim? Are you going to just get buy-in, or are you going to get real input?
I never got told anybody that I'm going to do consultation. I don't know where that come from. Consultation for what? I said I'm doing road shows. For instance, when I went to KZN, I'd already been to Sefako Mahatu that morning, and in the evening I went to KZN. It was not part of my road shows. They called me. They invited me and said, we want to hear more about this NHI. We are confused because the media is confusing us.
I hear you that we need the correct information on what universal access to healthcare is and also what the NHI will do. But within your government of national unity, the second largest party is the DA. And they love private medical aids. Their health policy is based on expanding access to medical aids, when the NHI plans to do it in a different way, by changing medical aids in their current form so that they don't provide the NHI services but only top-up services. How are you going to get the buy-in of the DA?
Look, we went into the government of national unity knowing very well who we are going with. We knew, and nobody said people who go into government of national unity are alliance partners. They are not. We are not an alliance with DA. We just went into a government of national unity with them because the situation demanded it. We know the policies are market related, business related, and our policies, for instance, is on the mixed economy. We knew there will be such contradictions. We'll sit down with them and resolve them. If anybody believes because of this misunderstanding, then the government of national unity should collapse, that will be very unfortunate, but what can we do? That will have been their choice. I'm not going to sit with anybody who totally doesn't want any reform on healthcare system financing. That will be a complete waste of time because they've made up their mind. So I'm going to people who are willing, who want to understand, but who are willing to make proposals about improvement.
So proposals about improvement, does that mean improving the NHI Act, or does it mean improving the health system in general?
No, I don't want to preempt that. It's not me who said I don't want anything in this form. It's the people. I want to listen to them. When you say you don't want universal, you support universal health coverage, but in this form, in which form do you want it? I want to listen. Maybe I can learn something that I never knew about.
So if there's something that a party who supports universal access to healthcare but has suggestions, for instance Section 33 about medical aids, would you be prepared to compromise in some way, or is it staying like that?
Compromise where?
Let it go.
Where? What must go?
If they
NHI?
say, if they say the NHI can be there, but they want medical aids, they want the right to a medical aid and to get NHI-like services from a medical aid, would you say that can change, or would it stay the same?
What would that mean? You can't come to me and tell me that, no, I support this universal coverage, but it must go. Because that's exactly what you'll be saying. Well, if there's a house which has been built and you say, I support this house, but I want the foundation to go, the roof and the walls will remain, don't you know that it's going to collapse?
Do you think there's a chance that the GNU, that there would be a repeal of the Act or a request for that, or how do you think things will play out?
Let's leave GNU out, Mia. I've been in government for ages now. I've never seen an act on earth that is never amended. I've never seen that. Even the Constitution itself has gone through amendments. There is no law on earth that is cast in stone, that never changes. I want to put that clear. And your colleagues, they will go and write and say, Minister is saying NHI is going to change. Simply because I'm making a statement, because I'm being honest. Just put a law here on the table which no human being can change. All the laws have changed. And you change them if you think it's necessary.
You've mentioned the legal challenges at the beginning of our interview that you had to study through, and there, I think about 6 of them that might go to court. How do you think that's going to play out? Is it a stressful factor for you?
There are 2 court cases already. The dates have not yet been decided upon. The 2 cases are still going to go in. I've got cause to believe there are more, definitely. There's no way there are only going to be 2. There will be more. And we are busy preparing for that. We are busy sitting together, preparing for that, gathering as much information as we can get. We will put in front of a judge. If we are wrong, we'll accept it. We are part of a constitutional democracy. If other people are wrong, they also must accept it.
Something you've received a lot of accolades for is when you were health minister the first time around, you really expanded our HIV treatment program. It became the largest one in the world. And if we look at the NHI, today we still have about 400 new infections each day, but the NHI says undocumented migrants can't get ARVs. Is that wise? What's the logic behind that?
It's a little bit more complex, that issue about undocumented, because undocumented people are generally not known. What I heard, which was a matter of concern, is asylum seekers, because that's not what the Immigration Act say. So if there's a mistake in the NHI Act about that, it needs to be corrected. But the whole issue of people being undocumented is very complex. We are going to have to sit as a continent to deal with this matter. I can tell you it's not going to be solved by one country, least of all by one minister. We are giving ARVs to everybody.
The NHI Act does say that notifiable diseases will be the ones that we would give treatment regardless. And HIV is not a notifiable disease. So with the ARVs, we won't be giving that, right?
Look, Mia, I know that HIV is not notifiable, but it falls within the definition of notifiable disease. It's not notifiable because South Africans refused. We stigmatize HIV/AIDS over a long period of time. People are refusing that notifiability. And in fact, if it was officially notifiable, I think we'll have gone a long way, because we'll have known who is where, if you understand what I mean. Because notifiability for a disease is to make the health system know who is where and who is infected. So the fact that legally South African refused us to put as notifiable does not mean that we must not treat it like a notifiable disease. And I'm sure when they said notifiability, they were not thinking they are excluding HIV, because we are treating everybody with HIV positive.
But for NHI and ARVs, we will aim to treat everyone. Is that what you're saying?
Because otherwise, I don't think we'll be able to defeat the disease.
More from the Minister after the break. You with Healthbeat, we're interviewing Health Minister Motsoaledi, who was present at Bekasisa's launch more than a decade ago in 2013, and we're both still going strong. Dr. Motsoaledi, the finances and the NHI, where is all the money going to come from?
Mia, I've been asked that question many times, and I throw it back in a form of a question. Where is the money to run the present healthcare system coming from? Because it's a lot, believe you me, it's a lot. And there are not many countries that have got that amount of money. But we are running a healthcare system with it. So as far as I'm concerned, we don't need new money. It's only that it's mal-distributed. That's the problem. NHI is a redistribution of resources that already are there. NHI is that mechanism where you pull funds for everybody. You don't pull funds for the selected few who are rich with heavy subsidies. Because people will tell me, those who will be listening will tell me, this minister is mad, that's private money. How private is it? This government, which is struggling to build hospitals and clinics in rural areas, is subsidizing private health care for 100 billion rand every year. 70% is subsidies to medical aids directly from Treasury into the pockets of those who are working for the state, who are on medical aid. The teachers, the nurses, the politicians, the judges, the magistrate, the police, the army, all those. Then, on top of that, every person, regardless of who has employed them, as long as they are on medical aid, they get tax rebates. And those tax rebates are 30 billion. When you add that money, it's 100 billion. It goes only to the rich, not to the poor.
So if I understand you correctly, you're saying that the medical aid premiums of government employees, of everyone who belongs to medical aids, that money can be redistributed to go to the NHI?
If we have got NHI, there's no need to subsidize anybody, or there's no need for tax credits to anybody.
There's been criticism about taking government subsidized medical aid benefits away from someone's employment package, that some health economists have said that you can't just do that, even if there's the NHI, that it's a package that they get and you can't unilaterally do that.
That's great now. Who put up that package? I've just told you earlier on that there is no law that can never be changed. These are laws that were put by human beings. Some of them put in laws that are favorable to them.
How are you going to ensure that the money that the NHI gets does what it's supposed to do and doesn't appear along the way?
I'm not about to deny the fact that there's a massive corruption in health. That's why together with SIU, we have launched the anti-corruption unit. These are the things that we can't live with in this country. Because the issue of corruption is a sort of a political culture which people cultivate and society accept.
That's our August edition of Healthbeat. Stay well and check out our stories on bekasisa.org.